Hello and welcome to Science of Medicine. Today I want to talk about some medical imaging techniques and the physics behind these. I'm not going to talk about all of the medical imaging techniques that are used in medicine. There are some very important ones such as ultrasound that I will not discuss, but this gives an overview of many of the ones that are actually in use. So there are different interactions between electromagnetic radiation or radioactive particles and matter, and only some of these are important in medical imaging. For example, absorption is a very critical one that is used as an interaction between the radiation and the matter that will lead to images. Scattering is an unavoidable consequence of interaction that degrades images in many cases. If I don't absorb radiation, then it will be transmitted, and that will be another thing that will be used as a means of imaging. I will sometimes have what's called pair production, and things like reflection and refraction and diffraction are less important in medical imaging, although certainly some of those are used in very specialized portions of medical imaging. So some of the modalities that have been used and currently are used in medical imaging include using X-rays, which are very energetic forms of electromagnetic radiation. These are things like your traditional X-rays that might be imaging your chest or your abdomen or a bone, as well as the 3D version of this, which is computer tomography or CT scanning. Radio waves, which are not very energetic, are used in magnetic resonance imaging. There are many radiochemical methods. Those radioactive methods include things such as myocardial perfusion studies, ventilation perfusion studies for looking for blood clots, positron emission tomography, bone scan, as well as a thyroid scan. And I hope to touch upon each of these. So some background. Remember that electromagnetic radiation has a certain energy associated with each wavelength. In general, wavelengths that are very, very small or short are going to have very high energy. So things such as gamma rays and X-rays are very, very energetic because they have very short wavelengths. In contrast, things such as radio waves that are used in magnetic resonance imaging have very, very little energy. When that energy or that photon or that wavelength of electromagnetic radiation or light interacts with matter, one of the things that can happen is that it can be absorbed. So I have a pictorial right here where I have a piece of matter shown as this block. Light will come in, but it does not get transmitted. And that means that there is some change within the matter. For example, it might be that I move an electron from some orbit to another orbit. Or in the case of magnetic resonance imaging, I would have a nuclear spin change that would actually occur with this absorption. Now, very, very different energies. If I look at X-rays, because I'm choosing to have energies that are very, very high and therefore very potentially damaging. And we'll talk a little bit about that. So if I look at X-rays and if I look at the energy of this, for absorption, the probability of absorbing an X-ray is proportional to the atomic number cubed. It also relates to the energy, inversely related to that. So if I have an image that is formed from absorption of X-rays, it is much more likely that I'm going to absorb if I have a very high atomic number. For example, calcium, which is present in bone, has an atomic mass that greatly exceeds that of something like hydrogen. So hydrogen effectively will not absorb X radiation to any appreciable extent. So the contrast between where I have something absorbing and something that's not being absorbed is what I'll look at to form my image. So effectively for atoms that are less than 10 in the atomic, in their atomic number, the probability of this absorption is essentially zero and you won't see them. So here is a picture actually of an X-ray of a chest of a person. And in this X-ray, you can see several things. So the first thing that you notice are these very black type of objects which correspond to the person's lungs. Now the lungs have tissue in it, but that tissue is also with mostly air inside it. Air is going to be comprised of molecular nitrogen with some molecular oxygen, so about 78% nitrogen, about 21% oxygen. But that's in the gas phase, so the density of that is much, much lower than it is in the solid phase of the tissue. So that light, that electromagnetic radiation, those X-rays are not going to be absorbed. In contrast, this person has a device implanted in them, and that device actually is made up of a metal, or several metals actually. And you can see right here a very white area which corresponds to a part of that metal. You can also see the leads that are going to the heart for that device. And those are also much whiter. That's because those metals have high atomic numbers, and therefore they're absorbing the light. You will also see some white in the bony areas that you can see, as well as for the heart, which not only is a tissue, but also has blood coursing through it. And the blood, of course, has hemoglobin, and hemoglobin has heme, which has iron in it, and iron's atomic number is high. So this difference in atomic numbers leads to difference in absorbances, leads to differences in imaging in terms of contrast. Unfortunately, there are also two types of undesirable effects of interaction of X-rays with matter, and this leads to scattering. And both types of scattering, Rayleigh as well as Compton scattering, lead to a degradation in the image, and I'll describe that across the next few slides. So in Rayleigh scattering, I can have that photon of light interact such that an electron is scattered. So it's not absorbed, it's not going from one level to another, it's scattered without that absorption. And when it scatters, it's unlikely to be scattered in the same direction as it was traveling to begin with. And so consequently, it will tend to blur the image. It'll lead to a degradation in the image. Now that scattering probability doesn't go as the cube of the atomic number, but goes directly with the atomic number. Similarly, Compton scattering will also lead to a similar kind of blurring or degradation in the image, except now it's going to have an inelastic interaction with the between the photon and the atom. So whether it is Compton or Rayleigh scattering, both of them will lead to a degradation in the contrast. Now, if I look at an X-ray experiment, what I'm going to do is shine X-rays through some tissue, and I will measure the amount of X-rays that will come through that tissue. And the intensity of that X-ray is given by this expression. It's dependent upon the initial intensity of that X-ray, so I can actually expose more or provide more incident light or incident X-rays to image this, and exponentially related to a few other things. It's related to a constant which actually has to do with the absorption probability, the density of the material, as well as the thickness of the material, this X. So you can see that I have an exponential relationship between the intensity of light that gets through the tissue and its density, this thickness of the tissue, as well as this sort of coefficient that describes how it's interacting with the matter, which is also linked to what that particular atom is. So let's look at this a little bit differently. If I looked at just having absorption, I just had a photon of X-ray come in, the electron would be promoted, and I would be able to absorb that. if I had no scattering, no Rayleigh, no Compton scattering, then what would happen is I would detect a certain number of X-rays as I traveled through some tissue. Now suppose in this tissue I had a pocket which just had air, which would be expected to absorb fewer in this pathway, fewer of those X-rays, because I'm not going through as much tissue as going through something which would just have just tissue. And then imagine that I also had a little area that would have bone in it with calcium phosphate, and that calcium would absorb more of the X-rays than the surrounding tissue. So if I looked at the initial intensity going through, I would have some attenuation or absorption, reduction in that intensity from the absorption, and that I would see as I'm going through tissue. But once I hit the air, all of a sudden I would have less absorption of those X-rays, and that's because it has a segment that is just going through air and not really absorbing much. Similarly, when it went through the bone, it would absorb more X-rays, and as a result of that additional increase in absorption, I would get a decrease in the intensity coming through. Now, that's not life. Life has these complexities, including scattering from Rayleigh as well as Compton scattering. So if I look at the X-rays passing through the tissue, and I've drawn just some of them will be scattered by the tissue or can be scattered by the bone. And as they do that, the beam tends to spread out. And so what that means is that if I look at the initial intensity, I will still have an attenuation or reduction as it passes through the tissue, but now the difference in intensity through the air and through the bone are going to be smaller compared to the background because of the scattering. And that scattering, therefore, will decrease the contrast between this dark area of my air and this white area of my bone and the actual tissues, because the signal is actually smaller. So let's look at this in practice. So this is also a chest X-ray, and I need to tell you a little bit about some anatomy for the chest. So as you can see, I have an area which is dark, which corresponds to the lungs. And in the center, I also, and displaced to the left, I have a heart. And I have the left heart border and the right heart border that's here. You should also be able to see the spine. And the spine, vertebral bodies, lies posterior to the heart. And so you're seeing whitest area where you have the bone, and then on top of that is the heart. And so that's why you get a wider area. And you can even see the vertebral bodies right here, as well as the little discs that are in between the little lighter spacing. Now you'll also see bones, prominent bones. Now you've got ribs that are on the front, which are these ones that are coming down at an angle like this, as well as ones that are in the back, which seem sort of more horizontal in this. You can see the clavicles, which are up here. And you can also see the trachea, which is a little bit darker area right here. And as it splits down just above the heart, it bifurcates into two different bronchi, one on the right and one on the left. And those are the main stem bronchi. So I want you to understand some of the basic anatomy so that you can understand some of these images. This is a more detailed view with a pictogram, if you will, of what the heart looks like in this. And you can see that I have the left side of my heart as well as the right side of my heart. If you notice that I have the pulmonary arteries coming off going to the left and to the right. And you can sometimes, if there's fluid that builds up in here, you can actually see these pulmonary arteries. You can see the aorta going from the left ventricle and arching downward as it goes down through the thoracic aorta, as well as then into the abdomen. And so these are important structures that you want to see. Again, I mentioned the right and the left heart border. All right, so let's look at what this might look at. if you have things. So again, I have my lungs, I have my heart. You can see the aorta quite prominently here. You see the trachea going down and then bifurcating right here, going off to the left and to the right. But if you notice over here, this is darker and there's an area of whiteness. There's an area of opacity. This is because this is a person that has a pneumonia. They have inside the lung alveoli fluid. Could also be blood, and but in this case it's fluid. And that's going to also absorb some light and lead to opacity, lead to this whiteness. Now, again, this being a 2D projection, you can't tell, is it just on the anterior or the front side? Is it all the way to the back? There is a lateral view that you can also use of X-rays to tell something about how far it goes back. All you really know is that there is some opacity here, and that means that there is likely some either fluid or blood or some other material that is within the lung that is actually absorbing that light. If you look at this, you see something that shouldn't be there, which is this area right over here, which has an opacity associated with it. This is a mass. This ends up being a lung cancer, actually, in this case. But this opacity, you can see, is not present in other areas of the lungs. You see little bits of white that are going up here that are associated with some blood vasculature, but this mass, this well circumscribed kind of mass, you can see is not supposed to be there. In this case, you see more of a uniform whiteness, and in fact, actually, you get the hint, if you will, that it's sort of flowing upwards. And this is kind of what happens when you back up the plumbing in the heart. This is called pulmonary edema. When you have, if you remember from the physiology sections that we had talked about, the left side and the right side of the heart, if you back up the left side of the heart, it will back up from the left ventricle to the left atrium and go into the pulmonary veins, and then it can leak out or seep out and go into the lungs themselves. And when that happens, there's fluid that goes into the parenchyma, and that fluid is called pulmonary edema. And this is an example of that. Now over here is a little different. If you look at the left side of the lung and you look at the right side, you notice a couple things. First off, this right side is very black. It's not absorbing much. You can see the ribs, posterior ribs, just really perfectly. You also see this little mass down here. Now, this is called a pneumothorax. This is where the lung has actually collapsed and is lying down here. And this is simply pleural space. There's nothing in there. There's no lung tissue, which is why it's absorbing less, which is why it's blacker than this section over here on the left. Now, if I look down at my abdomen here, I have several things. You can clearly see the bony spine as it's going down in your pelvis. And then you can see some of the ribs on the bottom part. Your liver is going to lie over here. Now you also see these areas that are blacker. These are your bowel. And at any given time, you understand that you'll have some gas in your bowel. And this will be normal. In fact, you'll pass that out at some point. And so this is a normal abdominal film. And you'll see some types of gas. In contrast to that, this is a person that has an obstruction in their bowel. And you can see that there's not only these darker areas, but there's also a line. And that's because there's a fluid air level. There's gas, and then there's fluid up here. And this is an example of an obstruction that would be present in the bowel that would cause it. It's also, you see, bigger. It's more dilated in terms of these loops of bowel. Sometimes, to enhance contrast, I will give a person a compound that when he or she takes it in the gastrointestinal tract, it will provide for additional contrast. This person has taken barium sulfate. Barium has a high atomic number, and therefore it will show up as this whiter area, and it gives you much more definition in this X-ray of the bowel, and you can actually see the small bowel moving back and forth in contrast. Now, X-rays can also be used to image bones. For example, this is an image of the right knee. You can see in this two-dimensional projection, you have the femur. On top of that, which is really out in front, is the patella. Down below it, you have the tibia and the fibula off here on the side. And you don't see something in between. Now, if you remember when we were talking about the joints, you normally would have in between the bones articular cartilage, but cartilage is made of low atomic number molecules, and therefore it is not absorbing that much in the way of light. It also has a synovial fluid and proteoglycans, again, lower molecular weight than the calcium phosphate in the bone. In contrast, this is showing several fractures. In this case, a tibial fracture. This bone here, which you can see clearly has actually come apart from the tibia. This is the plateau of the tibia, and even has fragment over here. Similarly, if I look at the wrist, the two bones in my forearm, the radius and the ulna, this is a radial fracture, and you can see that fracture right here where there's this gap in between. That's because there's actually a break and there's not bone that's there. You also can see, particularly in this view, a little thing here as the periosteum is kind of has damage to it, and you can see this, as well as the carpal bones that you can see here in the wrist and the hand. So this is a radial fracture. Now, sometimes it would be easier to interpret things if you don't have a two-dimensional projection of a three-dimensional object such as your body. And so once we had the ability to store vast amounts of data in computers, people started doing these three-dimensional CT scans or computer tomography. And in this case, what's going to happen is you're going to be placed inside, on this table, inside a scanner, which is going to rotate and take X-rays in a 360-degree type of image to be able to collect slices of the particular portion of the body that you're actually doing these multiple X-rays, and then you can reconstruct that. So if I look at this, this is one particular slice through the chest, a CT image, and in this case, I see much better definition of the tissue within the lung parenchyma. And you can see these little areas right here, which are blood vessels that are a little bit larger going through. Now, in this case, this person was given an IV contrast agent that has likely iodine in it, which has a high atomic mass, so that, atomic number, so that it can actually absorb a bit more of the X-rays. You can also see in the same plane these little bronchial tubes, which is this little black circle here. You can clearly see the trachea, which is this black tube right here, as well as the heart at a certain level where it's having blood going out. Now, over here you see something which is this sort of, ill-defined area. This is a pneumonia. Now, before when I showed you the pneumonia, you couldn't tell exactly where that was precisely. Now you can tell where that actually is. You can actually get borders that are showing. You know that it's right up against the chest wall, for example. So very different view. But this is simply one slice of the chest. And you would actually take many, many slices so that you could basically scan up and down and see the actual dimensions of things like masses in particular. Remember when I showed you the pulmonary edema, this is much more clear display of those vessels going upwards and having that fluid going up, causing the pulmonary edema. This is again with an iodinated contrast. And remember, I showed you a lung mass before. This is an actual three-dimensional. This is just one slice of this unfortunately very spiculated and ill-defined mass of a lung cancer. I also showed you a picture of a pneumothorax. This is a great view of a pneumothorax. In this case, the X-rays were not being absorbed because there was no lung tissue here. Here is the lung sort of collapsed down in there. But when you saw it, you saw just the two-dimensional projection of this. And since you can image things with contrast media, such as iodinated contrast media, you can accentuate other things. This is a blood clot. This is actually what's called a saddle embolus because it's occurring across the saddle of this pulmonary vasculature. And you can see that the darker area of the clot, which would just be comprised mostly for imaging purposes of the iron, is very different than the iodine, which is absorbing this. And this is actually a very extensive saddle embolus. Here's a better view of different slices. In this case, this is slices across the head as you're going down, starting here at the top and then moving down, and you can see the brain. Now in this case, this white area, what is this white area? That's right, this white area is bone. That's going to have calcium phosphate in it, and you can see here at the calvarium at the very top, before you're scanning into brain tissue, it's nothing but bone. And as you go down, you can then see things. You can see here these little ventricles. The ventricles contain fluid, are not as dense as this tissue in the brain parenchyma. And then as you get down into the facial structures, you'll see more in the way of bone. Now, another way of medical imaging is with magnetic resonance imaging. The theory for this is the same as in nuclear magnetic resonance, which you may have learned about in, let's say, organic chemistry. But because nuclear has a bad connotation amongst patients as being radioactive, and this is anything but radioactive, they changed the name to magnetic resonance imaging. And in this case, what's going to happen is you're going to be placed in a large magnet, and that magnet is essential for forming the image, and I'll discuss that in just a minute. You will have a device that is placed over whatever you're going to image. In this case, this person's head and brain is going to be imaged, and so that's going to have a receiver and transmitter coil, which I'll talk about in a few minutes. And you'll be moved into the magnet, and you'll be imaged. All right, so let's talk a little bit about this. So the basics on the physics side for this can either be discussed in terms of a quantum mechanical view or a classical view. I'm going to mostly stick with a classical view as opposed to quantum mechanical, but many of you learn the quantum mechanical in organic chemistry. So if you think about a quantum mechanical state, magnetic quantum states, the nucleus, that is the spin states, are degenerate. They have the same energy if you have no external magnetic field, like B0. When you apply a magnetic field, the two spin states, if it's something like hydrogen, which is typically what's imaged, are no longer degenerate and they'll split. The magnitude of that splitting is dependent upon a constant called the magneto-gyric ratio, as well as some fundamental things like Planck's constant, as well as the magnetic field. So stronger magnetic field, higher energy. Now if I send in light with the proper energy, it can be absorbed and change a spin state from one state to another. Classically, we can look at this as the nucleus being a charged spinning object. And we know from our macroscopic view that any kind of rotating object has angular momentum. And so if I have a charged spinning object, I have a magnetic moment that's oriented on the axis of rotation. So it has a certain magnetic moment. This magnetic moment is dependent also upon this magneto-gyric ratio. Now, because I have them in a magnetic field, they're going to precess in that magnetic field. That means they're going to oscillate or rotate applied with the applied field, and there'll be a population that will be opposed to the field. Now, in general, I'll have a slight difference in the populations of those two, so that I'll have a little bit more aligned with as opposed to without. And so what happens is, if I send in a proper energy, that energy can be absorbed, that photon can be absorbed, and it will change the angle. And so the angle changes, and I can change, or I can choose what that angle will be. Typically, in these experiments, I will flip it 90 degrees, or you can flip it 180 degrees. Now, once that energy is absorbed, I have to relax, and there are two means for relaxing in this magnetic resonance imaging. The first is called spin lattice relaxation. And if I look at the magnetization at equilibrium, this change in magnetization as a function of time is dependent upon magnetization along at equilibrium minus along a certain axis. I'm going to define three axes for doing this. So an MZ, this z-axis of magnetization, is the way I define for this spin lattice. And if I then take that differential equation and integrate it, I'll see that I have an exponential relationship between that magnetization and how it's going along the z-axis. That diminution along the that change in the magnetization has a certain time constant, which I'm going to call T1, and that depends upon the transfer of energy. What does this mean? So if I look at something like a hydrogen atom is ubiquitous within pretty much all tissues, and so it's the basis for doing a lot of our magnetic resonance imaging. In that hydrogen, it's got two states. It's got that are degenerate in the absence of a magnetic field. I put the tissue into a magnetic field, that degeneracy is removed, and I have a gap between them. The gap is teeny, teeny tiny. In fact, the thermal energy of you rubbing your fingers together is greater than the energy that would be associated with that nuclear magnetic spin. But I can have a change in that nuclear magnetic spin by sending in the right wavelength, and that turns out to be in the radio frequency range. And so that's what I will do. But once I try to relax, the spin lattice relaxation says, well, I'm going to transfer that small, infinitesimally small amount of energy from the hydrogen atom to the surrounding tissue, the lattice. And in order for that to happen, I have to have good interactions to permit that. And those interactions will be sort of the tumbling of those protons in the matrix. So we think about this as things that happen very quickly or things that happen very slowly. So if I'm a water molecule, which would have two hydrogens, there's a lot of freedom of movement in that. It tumbles a lot, and they're very, very fast movement, and so that leads to a very long T1. It leads to a very long time before you can transfer that small amount of energy from the excited nuclear spin state to the lattice. But I could have water that's bound by some number of interactions. The more of them, the faster that relaxation is going to be. And so this T1 relaxation is something that allows me to accentuate about things in the environment that would have lots of hydrogens, or water in this case. T2 is a little different. Now, T2 is looking along a different axis, that y-axis, and it's hypothesized that it will actually also have a time constant associated with T2, but it's a spin-spin relaxation. That's kind of a misnomer in my view to call it really a relaxation, because what's happening is that you're having a hydrogen ion, or a hydrogen atom that has a spin state that's excited, and it comes up with another hydrogen atom which is a spin state which is in the ground state. And what will happen is you'll have a transfer of that energy from one to the other. You still, at the end of the day, have the same number of excited state nuclei as you do as spin states as you did, a few hundreds of milliseconds before. But what changes is the entropy of the system. It tends to spread out the signal along, in this case, in the y-axis. And so that can be used also as an imaging modality. And so I can have these protons, these hydrogens, present in different environments, fluid, which would give me a very long T2, fat, which would give me a short T2. So my experiment is that I place the patient into a large bore magnet, and I place over the patient's area that I'm going to image, in this case, in this particular picture, it would be over the head, a radiofrequency coil. Now that radiofrequency coil is going to allow me to send out a pulse of radiofrequency radiation that will excite those spin states, and then I turn it off and I listen. It's actually the detector also. And so as I excite those nuclei and then observe them, I can think about different types of experiments that I could do. I can change the repetition pulse time. So I pulse it to change the angle that the spin states are making, that they're actually oriented on. Or I could actually listen for different times, the echo time. And so by changing these, I can change and accentuate what I actually want to get in my images. And I'll talk a little bit more about that. One thing that I need to do, though, is I need to be able to figure out where in this little detection scheme I'm actually at in my magnetic field, because this magnetic field itself is fairly uniform. They try to make these exceptionally uniform, and they do a wonderful job of that. So what happens is that I take and superimpose a very small magnetic field gradient. And if you remember that the precession frequency, and therefore the absorption of radiation, is dependent upon the applied magnetic field. So I have some big applied magnetic field, B0, plus a little magnetic field, B1, that's changing with position. And so that allows me to extract what the position is by knowing what that resonance frequency was when it was done. And you just need to make sure that you center the person so that you can start off and say, okay, I know exactly where this person is, which is why you can't move around inside an MRI and have any kind of accuracy in terms of position. And many times you'll see what's called a motion artifact when the patient will actually move around. So, as I mentioned to you, signal, we look at spin lattice and spin-spin relaxation, also the actual density of protons or of hydrogens. And I can select for the T1 or the T2 using these repetition or echo times. So what kinds of experiments can I do? Well, there are many pulse sequences. I'm going to talk about just a few of the typical ones that are actually used. So I have spin echo techniques where I can do T1, T2, and also a proton density. There are what are called inversion recovery, or FLARE, which stands for fluid attenuated inversion recovery. There's a diffusion weighted image, which I use for the determination of acute stroke. And I can also use gadolinium contrast agents, and I'll talk about that in a minute. So let's look at this. So this is an example of an MRI. This is a slice through the brain that is a T1 weighted image. And in a T1 weighted image, the fluid is going to be dark. The fat is going to be white. These are the white matter tracks, right? So these are the myelinated neurons as they're going, the axons that are going down. And then you have soft tissue, or in this case, the cortex, which is shown here in this gray. What's this white area right here? Well, if you said bone, that's wrong. This is MRI. This is fat. This is fat. It has nothing to do with what the CT images that I was showing you earlier were. Now, in contrast to a T1 weighted image, a T2 weighted image has the fluid, these ventricles, the cerebral spinal fluid, as showing as white. And now I can actually look at the tissue as being sort of the darker portions, which you can see here. Now you can see these white matter tracts, which are actually gray in this T2 weighted image. And you can see the cortex very nicely. Proton density is another type of imaging that's used, and this is mostly used to accentuate joint pathology. This is actually an MRI segment through the knee, where I have the femur and the tibia here. And in this case, what I can see over here, I can see now actually between the joint, and I can see a little area over here of pathology that is abnormal. You don't see it also on this side. And so proton density a lot of times is used for joint pathology. Sometimes you want to use inversion recoveries. And so this flare is a way of sort of hanging out your dirty laundry, so to say. So this is actually a good way of showing if there's some problem going on. This portion right here is actually in the tentorium, and this is where there's a layer of meninges that are over here. And this is actually a meningitis. And so the flare images will show things like multiple sclerosis. It'll show old strokes, meningitis, certain kinds of intracranial bleeds are highlighted or accentuated on this. They're more white. Now, diffusion weighted image is used really only for determining diffusion restrictions, such as in an acute stroke where you have edema that results. And this is a view also of the brain where this processed diffusion weighted image shows this white infarct and ischemic stroke that actually has occurred. I mentioned to you that you can use a gadolinium contrast. Gadolinium compounds, gadolinium is an element that has 7 unpaired electrons, and that allows a different relaxation pathway, so you can actually enhance things. This is pre and then post contrast. This is used especially for various types of brain tumors, and you can see this took up contrast exceptionally well. So let me ask you a question. Here's an MRI image, and this MRI image is of the spine. You can see the vertebral bodies and the discs and the spinal cord. And here's some sort of a mass. So which of the following do you think that this mass is maybe made out of? Do you think it's a fluid-filled cyst or a fatty mass or tissue that's similar to the spinal cord neurons? Do you think it's bone? Or do you think it's predominantly a water-based soft tissue? Well, I hope you recognize that this is a fatty mass. And how do you know that? Well, first off, you have to figure out what kind of MRI you're looking at. This is a T1 MRI, right? You can see the cerebral spinal fluid is black, it's dark, like in a T1. And in a T1 MRI, fat is white. And that's how I know something of what that is made of. All right, so let's talk a little bit about some radiochemical methods. So elements have a band of stability that as they increase their atomic number and their number of neutrons, that if they lie off of this, this band, they're unstable and they'll decay or throw off particles or energy to try to return to that band of stability. And how they do that, or what method they do that, depends upon where they lie on that band. So I'm going to talk about the methods that are used for medical purposes. So one type of decay is called a beta decay. Now in a beta decay, I have 2 possibilities. I can either give off a beta particle, I can give off a negatron. And in those cases, those are nuclear changes, right? So I'm changing from fluorine, atomic number 9, to oxygen, atomic number 8, by giving off this particle. And that's simply because, you know, the subatomic particles that are making up my atoms also are made up of subatomic particles. I also get an energetic particle called a neutrino, which I don't actually use medically. But I can detect these beta particles, all right? They don't ionize so much as, let's say, alpha particles, which are helium nuclei that come off, but they can undergo annihilation with an electron and form energy, which I can also detect. A very typical type of decay is gamma radiation. Now, gamma radiation is when a nucleus goes from an excited to a ground state. This is different from, let's say, X-rays, where I'm talking about electronic transitions, electrons going, not a nuclear transition, which is even more energetic. And I can actually, since these gamma rays penetrate very, very deeply, you have to wear shields. That's why they put these lead aprons on you in areas that are not being irradiated if you have one of these. And this is detected, and you can then see what kinds of materials are being given. I see you can detect the intensity of that coming off. All right, so how is this used? So there are several ways that this can be used. So one of them is a myocardial perfusion study. So sometimes people will have chest pain, and when they have chest pain, it can be from the heart. And one of the ways to tell if there is blockage in one of the coronary arteries, one of the arteries that's supplying blood to the heart, is to do a myocardial perfusion study. Now, a myocardial perfusion study involves you injecting a radioactive substance into the person's bloodstream and looking at images when the heart is at rest and then when the heart is actually being used. So either the person is up on a treadmill or you put something into their bloodstream that makes their heart race. And when this happens, if there are blockages, then you cannot perfuse that area of the heart, and it shows up differently at rest and when it was under stress or basically in use. So we use two possibilities. We can use a thallium isotope, thallium-201, which is a gamma ray producer, or a technetium, which is a metastable acetonitrile analog, cestamide, and that's also a gamma ray producer. So when I look at this, when I actually do these, I can look for differences in the way this actually is imaged. And these are false colors to give me intensities of that radiation that's given off. Another radiochemical method is to try to detect if there's a blood clot. This is a ventilation perfusion scan. Now, I could detect if there's a blood clot by simply doing an iodinated contrast agent and doing a CT scan, absolutely positively, and that's done very frequently. Sometimes, however, you can't use contrast agents. Perhaps the person is allergic to it, perhaps they have kidney issues, and you have to use this technique. So in a ventilation perfusion scan, I'm going to use two compounds. I'm going to have the person inhale xenon. Xenon is a noble gas, and xenon-133 undergoes beta decay. And I also will introduce into the person's vasculature a technetium metastable. In this case, it's an albumin analog for technetium, which is a gamma ray producer. So I look at the image from the xenon decay, and I look at another with the technetium, and the differences will show up as defects between the areas that were imaged from the xenon, which is the ventilation, and the areas that were perfused or not perfused as shown. And those differences will show up as are being ascribed to whether or not it's likely that there's a blood clot that's causing it. And this is called a VQ, or a ventilation perfusion scan. Another thing that you may have heard of is called a PET scan, or a positron emission tomography. In this case, a radioactive isotope of fluorine, fluorine-18, that is attached to deoxyglucose. So this is glucose that basically has a radioactive tag on it, is given, and then it will actually undergo positron. And that positron that actually will be given off, that's that beta plus particle, that positron will then annihilate with an electron and give a gamma ray that I can detect. And so high metabolic activity, high metabolic areas are going to want to show up in terms of this. And so you can see metabolic activity from things like cancers or from certain types of infection. A bone scan is used to also look at areas of high bone turnover or metabolic activity. And this uses another technetium analog. It's a metastable one. This one uses bisphosphonate, which will accumulate in bone. And it's the gamma ray detector, just like before for the other technetiums. And then it shows up with these black spots. Now this actually down here is just the bladder where it's accumulating. But you can see in the pelvis as well as throughout the axial and even the epidicular skeleton, you can see those black images. And that shows areas of pathologic activity, mostly cancers and infections. There's a specific thing which is a thyroid scan. Remember, the thyroid is located in your neck. And I use, in this case, a radioactive iodine isotope, either 131 or 123, that either gives you a beta decay or gamma ray detection. And what this will show is uptake, abnormal uptake of that radioactive iodine, or not so. So either areas that are hot or cold based upon that. So this has just been a very brief overview of some of the physics of medical imaging. And I will see you in a little bit, and we will talk about the optics of vision.